Welcome to the Deep Dive. Today we're looking into something that carries quite a bit of hope for families. Hyperbaric Oxygen Therapy, HBOT for short.
That's right. Specifically, we're exploring its potential use for kids with cerebral palsy, or CP.
We've really gone through quite a stack of sources here, medical journals, study reports.
Yeah, we're aiming to see what they tell us. Where did this idea even come from? How is it supposed to work? And really, what does this research actually show?
Right. Our mission basically is to pull out the most important bits for you so you can get a clearer picture of, well, the potential upsides and maybe the lingering questions about HBOT for CP.
Exactly.
Okay, so let's dive in. Maybe we should start with the basics. Just remind everyone, what exactly is cerebral palsy?
Good place to start. So cerebral palsy, CP, it's not one single disease. It's more like a group of conditions.
Okay.
And they all involve problems with movement, motor impairment. The really crucial thing is that the original brain issue, the lesion or anomaly, it doesn't get worse over time. It's non-progressive.
But the way it looks can change as a child grows.
Precisely. And it all stems from some kind of damage or unusual development in the brain happening really early on.
And it's actually quite common, right? I remember reading that.
It is, yeah. The sources we looked at say it's the most common physical disability of childhood worldwide.
Wow. Any numbers on that?
Yeah, around 2 for every 1,000 live births, give or take. It's significant.
So what causes it? What leads to that early brain damage or difference?
Well, it can be a whole range of things, really, and they can happen at different times, too.
Like before birth?
Yeah, prenatal causes, things like infections the mother might get during pregnancy or maybe an injury to the baby while developing.
Okay. And around the time of birth?
That's the perinatal period. So, yeah, things like being born too early, premature delivery, or maybe a really difficult birth. Low birth weight, trouble breathing right at the start. Those can be factors.
And even after birth?
Sometimes, yeah. Postnatal causes. Maybe infections like meningitis or a head injury, sadly. Or even lack of oxygen from something like a near-drowning incident.
Now, there was something interesting in the sources about a common idea. A misconception, maybe.
Yeah.
About the main cause.
Yes, that's really important. For a long time, the sort of dominant idea was that lack of oxygen during the birth itself, intrapartum asphyxia, was the primary culprit, especially for full-term babies ending up with brain issues and CP.
That's been challenged.
It has. More recent research using things like MRI scans, detailed brain imaging, and also postmortem studies. They just haven't consistently backed that up as the main cause.
So what do they point to then?
It seems like events happening right around the birth or just after the immediate perinatal period, as it's called, are often more significant for causing that brain injury in newborns.
Okay. So not necessarily the labor itself, but that very early window.
Kind of. I mean, things during pregnancy or maybe genetic factors might make a baby more vulnerable, sure. But the actual injury often seems to happen right around delivery or very shortly after.
Okay, that feels like a key distinction. And how does that connect back to the idea of using HBOT early?
Well, it highlights this potentially crucial window, doesn't it? If the most damaging phase is often right there in that immediate time around birth.
Then an early intervention might make the biggest difference.
Exactly. Something like hyperbaric oxygen therapy, applied really early, might theoretically have the best shot at minimizing the damage, maybe even preventing CP from developing fully.
Makes sense. Okay, so let's shift to the therapy itself, HBOT. It sounds modern, but the idea of using oxygen medically, especially for newborns, that's been around a while, hasn't it?
Oh, absolutely. Yeah. After World War II, there was this big push, using oxygen tents, incubators for premature babies, trying to boost survival rates.
And the thinking was just more is better.
Pretty much, yeah. They were using really high levels back then, sometimes like 70% oxygen for long stretches.
But that didn't end well, did it? There were problems.
Tragically, yes. That period saw this sudden rise, an epidemic almost, of something called retrolental fibroplasia. We know it now as ROP, retinopathy of prematurity.
And caused blindness.
Many, many infants, yes. It was a terrible consequence, and it directly led to doctors cutting back on the amount of oxygen they gave, aiming for maybe around 40% instead.
Did that fix the ROP problem?
Well, the number of blindness cases definitely dropped, so it seemed to confirm that, too much oxygen was the bad guy.
But maybe it wasn't that simple.
Exactly. Some researchers, like Suzik back then, started noticing maybe it was more complex. They suggested it wasn't just the high level, but maybe the changes in oxygen levels.
Like taking them off the oxygen suddenly.
Right. The eye problems often showed up after the baby came out of the high oxygen environment. It wasn't always while they were in it.
Interesting. So not just the dose, but the withdrawal, too.
Seems like it. Later on, researchers like Bedrosian and Forrester found that if they weaned babies off the oxygen more slowly, gradually.
Fewer cases of ROP?
Exactly. And Forrester even did something quite radical, sometimes putting babies back on oxygen briefly, then doing a really slow reduction. And in some cases, it seemed to help restore vision.
Wow. So just cutting oxygen wasn't the whole answer.
Definitely not. And our understanding, like the biology behind it, evolved too, right?
Yeah, what did we learn later?
Much later, yeah, decades later, research focused on this substance in the retina called VEGF, vascular endothelial growth factor.
Okay, VEGF, what does that do?
Think of it like a signal telling blood vessels to grow. And the theory became that these big swings in oxygen, high, then low, maybe back again, messed up how VEGF was regulated.
Leading to abnormal blood vessel growth in the eye.
Precisely. That abnormal growth is sort of the hallmark of ROP, and the fact that modern treatments blocking VEGF actually work for ROP kind of supports this whole idea.
Okay, so that's the complex history with regular oxygen therapy. How does HBOT fit in? And crucially, what about that ROP risk? Is it a concern with hyperbaric oxygen?
That's a really critical question, and the sources we looked at are pretty consistent on this.
Yeah.
They indicate that ROP is not seen as being associated with HBOT.
Regardless of the pressure or duration?
Apparently so.
No.
Regardless of the pressure, how long the sessions are, or even how they stop the treatment. Studies in rats, even at pressures like 1.8 ATA.
ATA being atmosphere's absolute the pressure measure.
Right. So even continuous exposure in rats at 1.8 ATA didn't show retinopathy, unlike rats kept in high oxygen at normal pressure for long periods.
Okay.
And another study using both normal rats and a rat model of CP found that even pretty high doses of HBOT, like 3.0 ATA for an hour, didn't cause retinal damage or weird blood vessel growth.
And in human babies?
There was a study on newborns who'd suffered lack of oxygen to the brain. They got daily HBOT at various pressures. It actually improved their levels of protective antioxidants without causing any retinal damage.
That's huge. So the fear of ROP, based on that old oxygen tent history, shouldn't really apply to HBOT.
Based on this evidence, it seems not. It's a different mechanism, different exposure.
Okay, that's a really important clarification. So let's move on to the early uses of HBOT, specifically in kids. Where did that start gaining traction?
Well, the sources point quite a bit to Russia. They seem to have used it quite widely in pediatrics early on.
For what kinds of things?
Newborns, mainly. Resuscitation if they weren't breathing well, for brain injuries during birth, even for something called hemolytic disease of the newborn, where red blood cells break down.
And they felt it helped?
They claimed it did, yeah. Said that giving HBOT really early, like within 1 to 3 hours of birth, could lower bilirubin levels, that's the stuff causing jaundice, and maybe prevent neurological issues later.
Wow, that early.
Yeah, they even felt that waiting longer, say 12 to 48 hours, was too late for helping with breathing problems in newborns.
Was it just Russia exploring this?
No, not entirely. In Italy, starting in the late 80s, some doctors were actually treating fetuses in the womb with HBOT.
Really? While still pregnant?
Yeah. They reported seeing improvements in the baby's biophysical profile, sort of measures of well-being, after just a few sessions for the mother.
Fascinating. Anywhere else?
China, too. Physicians there apparently have a lot of experience using HBOT for newborn resuscitation. Reviews of their studies, looking at HIE, that's hypoxic ischemic encephalopathy, brain injury from lack of oxygen.
Right.
Those reviews, while noting maybe some study limitations, generally showed fewer deaths and better neurological outcomes with HBOT, and that lined up with what animal studies were showing too.
So quite a bit of early exploration, maybe not always super rigorous by today's standards, but pointing towards potential benefit in newborns. What about for kids who already had CP, chronic CP? When did HBOT start being looked at for them?
That seems to have picked up more in the late 1980s. There was this conference in 1989, apparently, where data from Brazil was presented.
What did it show?
It was on a pretty large group of young kids with CP. They'd been treated with HBOT at 1.5 ATA. And the report said a big majority showed a noticeable drop in spasticity, that muscle stiffness.
Just from the HBOT.
That's what they reported. And follow-up data on some of them suggested these improvements lasted. Not just spasticity, but also motor control, balance, attention. They even said less frequent seizures and bronchitis.
That sounds quite significant. Were there other similar early reports?
There was a study out of Bulgaria, presented a bit later, looked at 50 kids with CP. They found a good percentage showed improvements in overall development, motor skills, thinking abilities, speech after HBOT.
Any downsides mentioned?
They did note some transient unwanted effects in a few kids, but said they went away after treatment stopped. Didn't specify exactly what those were in the summary we saw.
Okay. And North America?
The first reported case seems to be 1992, a child with hypotonic CP that's low muscle tone who couldn't walk. After HBOT, the report says the child started walking and showed other gains.
And these kinds of stories had an impact.
Yeah, it seems so. These positive anecdotes led to a charity being set up in the UK. It was called the Hyperbaric Oxygen Trust initially, and now it's called Advance, focused specifically on providing HBOT for kids with CP and brain injuries.
Okay, so you've got these early observations, anecdotal reports, some non-randomized data,
Yeah.
promising signs. But then what happens when researchers start doing more formal, published clinical trials, the kind with more controls?
Right, that's where things often get more complicated, or at least more debated. The first published pilot study in North America was Montgomery and colleagues in 1999.
What did they do?
They looked at kids with spastic diplegia CP mainly affecting the legs. They gave them HBOT and measured changes using the GMFM, the gross motor function measure.
Which is a standard assessment.
Exactly. And they found an average improvement on the GMFM scores after the HBOT. No serious side effects reported, and videos apparently showed positive changes too.
But were there limitations?
Yeah, definitely. It was a pilot study so small, and crucially, no placebo or control group getting a sham treatment. They also used a couple of different HBOT protocols, which makes it harder to interpret. And the researchers themselves pointed out that the improvements seemed to fade kind of quickly after stopping treatment. They suggested maybe more treatments were needed.
Okay, so a hint of benefit, but questions remained. Then came the Collett study in 2001. That one seems to get mentioned a lot.
It does. It was much larger, multi-center, involved 111 kids with CP. They were randomly assigned to one of two groups.
What were the groups?
Group 1 got 41-hour sessions at 1.75 ATA, breathing 100% oxygen, standard HBOT, basically.
Okay, and Group 2?
Group 2 got the same number of sessions, but at a lower pressure, 1.3 ATA, and they were breathing just normal room air, not extra oxygen.
So HBOT versus slightly pressurized air, what did they measure?
Motor skills, gross and fine memory, speech, language. Quite comprehensive.
And the results? This is the controversial part, right?
It is. Because surprisingly, they found the improvement in overall motor function was statistically pretty much the same in both groups.
Really? No difference between 100% oxygen at higher pressure and room air at lower pressure?
Statistically, no significant difference overall. About a 3% improvement in the pressurized air group and 2.9% in the HBOT group. Now, they did note that in the kids with more severe disabilities, the HBOT group seemed to improve a bit faster.
Okay. What about thinking skills, cognition?
Similar story. Both groups showed improvements, but again, no statistical difference between the groups.
So reading that headline, you might think HBOT doesn't actually add anything beyond just being in a pressurized chamber.
Exactly. That was the initial takeaway for many. But then the debate started about that control group.
The 1.3 ATA room air group. Was it really a control?
That's the crux of it. Many experts argue, no, it wasn't an inactive placebo, because even 1.3 atmospheres of pressure increases the amount of oxygen dissolved in your blood plasma by about 50%, actually. So that group was getting a form of hyperbaric therapy, just a milder one, using the oxygen already in the air.
So it wasn't HBOT versus nothing. It was HBOT versus mild HBOT.
Pretty much. Some sources even speculate that maybe the 1.75 ATA pure oxygen dose was maybe even too high for some kids, potentially masking some benefits. It gets complicated.
So the conclusion wasn't as clear-cut as it first seemed.
Not at all. Some researchers felt the Collett study ended up confusing the issue more than clarifying it, because both groups did improve, measurably, more than you'd maybe expect from just, say, extra attention or therapy alone.
Which suggests that even mild pressure might be doing something.
That's the argument, yeah. That pressure itself, even with just room air, might have biological effects.
Okay. Were there other controlled trials around that time shedding any different light?
Yeah, a few others. There was a U.S. Army study looking at kids with brain injuries from lack of oxygen. Some had CP. They got 80 HBOT sessions at 1.7 ATA.
80 sections, that's a lot.
It is. They reported significant improvements in GMFM scores and also found parents needed less time for caregiving afterwards. Interestingly, they mentioned doing SPECT brain scans but didn't include those results in the publication due to some technical issues.
No. Okay.
A study from New Delhi. They randomized kids with CP either to standard therapy alone or standard therapy plus HBOT at 1.75 ATA. The group getting HBOT showed significantly greater improvement in gross motor skills, and their SPECT scan suggested there was brain tissue that could potentially recover what they call recoverable penumbra.
That sounds more positive.
It does.
Look.
And then there was the Cornell study, Packard, around 2000. It was randomized controlled. They compared starting HBOT right away versus delaying the start. Used 1.5 ATA.
What did they find?
Significant improvement in mobility for the group that started HBOT immediately. Parents also kept diaries, reporting improvements in mobility, attention, and language.
Interesting about the attention and language.
Yeah, and the researchers specifically noted that cognitive skills seem to show more lasting improvement with HBOT compared to just standard therapies, whereas motor skills might need ongoing treatment. They also mentioned some kids with cortical visual impairment showing vision improvements.
So again, despite the Collett study's ambiguity, other trials were suggesting benefits, sometimes quite specific ones like cognition or vision.
It does seem that way. There's this recurring signal, even if the trial designs make direct comparisons tricky.
Okay, so bringing us more up to date, say, since the mid-2000s, has the picture become any clearer with more recent research?
Well, there was a symposium back in 2003 that kind of noted this trend. Different studies, different designs, even using lower HBOT doses, were starting to report similar positive results in CP.
Okay.
And then a pretty significant review came out in 2007 by Senechal and colleagues. They compared HBOT against a whole range of traditional CP therapies, using the GMFM as the main outcome measure.
What did that review conclude?
It was quite striking. They concluded that HBOT showed faster and more impressive improvements in motor function compared to the other therapies, and importantly, they stated HBOT was the only therapy that also showed improvements in cognition and language.
That directly counters the idea that it's just, like, extra attention causing the improvements.
Exactly. It challenged the parent participation effect argument that came out of the Collett study debate.
Right.
If HBOT was uniquely improving cognition and language, that suggests a real biological effect beyond just enhanced therapy engagement.
Right. What about that Lacey study from 2012? I remember reading it. It was stopped early.
Yeah, the Lacey study, another randomized controlled trial. But again, the control wasn't inactive. They compared hyperbaric oxygen to, get this, hyperbaric hypoxic air.
So pressurized air with less oxygen.
Right. Another comparison of two different types of potentially active treatment, really. It was stopped early for futility.
Meaning it didn't look like it was working.
Well, the initial analysis didn't show a statistically significant difference between the groups in reaching a specific target, a 5% improvement on one motor scale. That was the trigger for stopping.
But was there any difference?
Actually, yes. If you look at the average improvement on the GMFM 88 scale, the HBOT group still improved more than twice as much as the hypoxic air group.
So stopping it might have been premature.
Some argue that, yeah. Or that maybe the study design, expecting a huge difference between two potentially active treatments, was flawed from the start. They did find similar improvements in both groups on another measure, the PEDI assessment, which kind of echoes the Collett findings again.
This issue of the control group really dogs this research, doesn't it?
It absolutely does. It makes definitive conclusions very difficult.
Any other key recent studies?
The Mukherjee study in 2014 is interesting, non-randomized, but they compared intensive rehab therapy alone versus intensive rehab plus 3 different HBOT protocols.
Including the 1.3 ATA air one.
Yes, exactly. That mild hyperbaric air was one group. The others were higher pressure oxygen.
And the results.
All 4 groups improved, which you'd expect with intensive rehab. But the 3 groups that got any kind of hyperbaric therapy improved more and faster than the rehab-only group.
Was one HBOT protocol clearly better than others?
Not really. There was maybe a slight trend favoring higher pressures, but no significant difference between the 3 hyperbaric groups. And crucially, the improvements in the hyperbaric groups continued during the follow-up period, after the treatments ended.
That suggests a lasting effect.
Potentially, yes. More than just a temporary boost during treatment. And one last one, a 2015 study using SPECT imaging again. Small, just 2 younger kids with CP from birth asphyxia. But after HBOT, their SPECT scans showed significant improvements in brain blood flow patterns.
Okay, so consistently seeing signals of benefit often across different measures, motor, cognitive, even brain imaging, but plagued by these study design issues, especially the lack of a true placebo. Let's talk safety. What do the sources say about risks or side effects?
The most commonly reported side effect by far is middle ear barotrauma.
Ear problems from the pressure changes.
Exactly, like on an airplane but more intense. Discomfort, pressure, maybe fluid buildup. Usually it's manageable though. Techniques to pop your ears, or sometimes tiny tubes, called tympanostomy tubes, might be needed.
Like grommets.
Yeah, basically. What else? Sore throat, pharyngitis was mentioned in one study.
Okay. What about seizures? That sometimes comes up with HBOT discussions.
It does. There were some reports in early studies or maybe individual cases, but the more recent, rigorous studies we discussed generally haven't reported seizures as a side effect in these CP trials.
So not a major concern in this context based on the trial data.
It appears not, overall. The general conclusion from the study seems to be that HBOT, as used for CP in these trials, is a pretty low-risk treatment.
Any serious issues reported at all?
There have been isolated case reports mentioning serious things like vomiting leading to aspiration or an infection leading to stroke around the time of treatment. But the sources argue the link back to the HBOT itself wasn't clearly established in those rare cases. It highlights the need for proper medical screening and having trained staff present during treatments, of course.
Absolutely. Okay, so pulling it all together then. Despite the complexities and the debates about controls, what's the main takeaway from this deep dive into the sources on HBOT for CP?
I think the biggest takeaway is that many of the studies, often labeled negative, weren't actually comparing HBOT to nothing. They were comparing different doses or types of hyperbaric therapy.
Right. HBOT versus mild HBOT.
Exactly. And when you look across the board, there's this really consistent pattern where various forms of HBOT, even just pressurized air, seem to show benefits compared to standard CP therapies alone.
And that's backed up by other lines of evidence.
Yeah, we saw the animal studies showing HBOT can improve cognition and blood vessel density after brain injury, and those SPECT-scan case reports showing better brain blood flow patterns in kids with CP after HBOT, matching their clinical improvements.
So where does that leave us in terms of recommendations?
Well, the sources suggest that the positive data that does exist is probably enough to recommend considering HBOT for CP, especially when maybe other therapies haven't given lasting improvements. You'd still want to be cautious with kids who have seizure disorders, of course.
But it's a valid option to discuss.
It seems so, based on this evidence.
Looking forward, what's needed next? More huge trials.
Ideally, yes, large trials with proper inert placebo controls would be great, but they're hard to fund and conduct. Perhaps more realistically, the focus needs to shift towards personalized medicine. Recognizing that CP is diverse and kids respond differently, future research really needs to figure out how to tailor the treatment, the right pressure, the right number of sessions, the right duration for each individual child. Which kids are most likely to benefit and from what specific protocol?
Fine-tuning the approach.
Exactly. Moving beyond just, does it work? To, how can we make it work best for this child? That's where the potential might really lie. But it requires more research, navigating that funding challenge, and addressing the ongoing debate in the medical world.
Okay. So, wrapping up our deep dive today, the research on hyperbaric oxygen therapy for cerebral palsy shows, well, a complex but intriguing picture. There's a body of evidence suggesting potential benefits improvements in motor function, yes, but also, maybe uniquely, in areas like cognition and language.
Definitely. And while the scientific conversation continues, and we absolutely need more research to figure out the best ways to use it,
This information hopefully gives you a solid starting point, something to understand the potential, the questions, and to discuss further with healthcare professionals if it seems relevant.
which leads us to a final thought for you to consider. Given how complex CP is and how varied the responses to HBOT seem to be in the studies we've looked at, how might future research, especially if it embraces that personalized approach we talked about, unlock even more potential for this therapy? How could we really tailor it to help individual children with CP reach their best possible outcomes?
Something to think about. Thanks for joining us for this deep dive.
We'll catch you next time.